This is the presentation that you can either use on an iPad or print and put in a flip chart for meetings with prescribers. So I'm just going to go through this as though I were meeting with a doctor. Doctor Personalized Medicine will allow you to add precision to your prescribing by tailoring medical treatments to the individual patient, using sophisticated molecular tools, which will allow you to achieve better outcomes with fewer adverse events. Personalized medicine is a substantial shift from what works for the typical patient to what works for the individual patient. And doctor, you know better than I do that there is no such thing as a typical patient. What pharmacogenetic testing will allow you to do is determine the right drug for the right patient at the right dose. Doesn't that sound like the way you would like to practice medicine? So what is pharmacogenetics? Pharmacogenetics is the study of how your patient's genes affect their response to drugs through metabolizing. It allows you to predict in advance how a patient is going to respond to a drug, which will allow for better medicine in your office. Because genomic differences influence efficacy, particularly for drugs that have a narrow therapeutic window. Genomic differences increase the risk of serious drug side effects, and genomic differences increase the risk of drug-drug interactions. So why would a busy physician want to perform pharmacogenetic testing in their daily practice? Pharmacogenetic testing will allow you to identify the likelihood of adverse drug events because, in fact, 25 to 50% of your patients have a polymorphism for a particular drug. 2 to 3 billion ADEs occur annually, and there's more than 100,000 deaths annually in the United States attributable to ADEs. Pharmacogenetic testing will increase drug efficacy, increase patient compliance and retention, and it is the standard of care because we've now seen this topic on the cardiology boards given in October of 2012, and genotyping for metabolizer status will be on the upcoming anesthesiology boards. When a topic has hit the specialty boards, I think you would agree with me, doctor, that it is standard of care. Pharmacogenetic testing will allow you to market your practice, mitigate risk, and reduce healthcare costs. Pharmacogenetic dynamics operates such that a patient group with the same diagnosis, given the same prescription, will have 4 very distinct outcomes. Some of the patients will have no benefit with toxicity. There will be another group of patients that have no benefit without toxicity. So what do you do with these patients? Reduce the dose? Prescribe a different drug? The reality is that would just be a second guess exacerbating the first guess that wasn't right. Pharmacogenetic testing will allow you to make educated clinical decisions in the first instance. The third group of patients will be those that have no benefit, no toxicity, thereby wasting therapeutic time and therapeutic dollars. What do you do with these patients? Prescribe a different drug? If so, what drug? Once again, pharmacogenetic testing will take the guesswork out of your prescribing. And then lastly, we have the category that we wish all of your patients fell within, but in fact they don't. These will be the patients that benefit from the prescription and have no toxicity. For them, that's the normal dose. But the reality is that for any patient group with the same diagnosis and the same prescription, there'll be 4 distinct responses. No benefit, toxicity, no benefit without toxicity, no benefit, no toxicity, and then the patients who are benefited from the prescription. A patient's genetic profile is something that you want to know in advance because it can help you adjust drug therapy to improve efficacy and reduce the risk of ADEs. This is based upon your patient's metabolizer status. Again, normal patients, normal drug response is expected because they're a normal metabolizer of that particular drug. Not all drugs, that particular drug, metabolized by that particular enzyme. We then have 3 categories of abnormal metabolizers. ultra rapid metabolizers, intermediate metabolizers, and poor metabolizers. For these three groups, knowing their genotype in advance will allow you to avoid risk of toxicity, risk of treatment failure, and the likelihood that they won't benefit therapeutically. So once again, you don't know in advance which of these four categories your patients fall within unless you do pharmacogenetic testing, quick, simple, easy, non-invasive test that takes 2 to 3 minutes to do. I think that through the years of your practice, you've realized that one size does not fit all when it comes to pharmaceuticals. One size does not fit all. And that's once again, doctor, because there is no such thing as the typical patient. And this graph shows you that with different categories of drugs, the numbers vary. But the reality is that there is no one size fits all. And pharmacogenetic testing will allow you to pick the right size, if you will, for your patient. It's quick and easy, done with the buccal swab. So it's simple, quick, and convenient. There's a no-cost test kit and on-site FedEx pickup. You will be provided with clinically actionable results that are easy to read, and they'll be delivered electronically to a HIPAA-secure database. Pharmacogenetic testing is covered by Medicare and most major commercial insurance providers, so you will be able to test the majority of your patients. The physician is reimbursed for interpretation, and there's a PharmD available for consultation at the lab. The reports are simple and informative. They're easy to read, and they're color-coded to alert when dose adjustment or alternative drugs should be considered. So once again, simple and informative. We make this as easy as it can be so you can incorporate it as broadly into your practice as you want to. There's a cardiac and a pain management panel. The cardiac medications include Plavix, beta blockers, warfarin, and risk factors, ApoE, factor 2 and factor 5, the two most common clotting disorders, and MTHFR. The pain management panel allows you to look at pain management drugs such as hydrocodone, oxycodone, fentanyl, methadone, etc. So two of the panels, again, are cardiac medication and pain management medication. The other two panels currently available is the psychiatric panel and the urology panel. The psychiatric panel speaks to antidepressants, antipsychotics, bipolar, and ADHD drugs. The urology medication speaks to prostate drugs, overactive bladder drugs, and erectile dysfunction drugs. So who's doing pharmacogenetic testing and what are they saying? Harvard Medical School teaches it. It's a required course. Beth Israel Deaconess, Georgetown Medical School, Vanderbilt, Stanford University, Scripps Howard, Columbia, Cornell, Duke, UNC, UPMC, all top 10, 15 hospitals. The NIH, the FDA, in fact, drug manufacturers are now incorporating pharmacogenetic testing into a concept they call tailored therapeutics, whereby they will develop different formulas of their drugs based upon metabolizer status. Tailored therapeutics is what, again, the pharmaceutical companies are calling their participation in this medical ancillary. The power in tailored therapeutics, so says the president and CEO of Eli Lilly, is for us to say more clearly to payers, providers, and patients, this drug is not for everybody, but it is for you. That is exceedingly powerful. The day of the blockbuster drug is over. The day of the tailored drug is upon us. The NIH has been quoted as saying, today, one of our biggest goals is to cut the cost of sequencing an entire human genome to $1,000 or less. This advance will pave the way for each person's genome to be sequenced as part of the standard of care, leading to a revolution in the practice of medicine. That day is upon us, doctor. And you can incorporate into your daily practice pharmacogenetic testing, and I'm here to support that effort.